Hello, I'm Dr. Jake Begun, a gastroenterologist from Australia with a subspecialty focus on inflammatory bowel disease. We face an unprecedented situation with a global pandemic of COVID-19. Understandably, there's a great deal of anxiety among our IBD patients and their practitioners. There are many questions about how best to manage IBD in this challenging setting. It's our priority as healthcare practitioners to minimize the risk of our IBD patients from COVID-19 while also managing their underlying IBD, preventing flares and complications. This video is based on the GESA recommendations and addresses the concerns of healthcare providers looking after IBD patients. Patients on immunosuppression may be at a higher risk of developing severe disease if they contract COVID-19 infection, although that evidence is still emerging and the magnitude of the risk remains unclear. The highest risk group of severe COVID-19 infection appears to be the elderly and those with underlying medical comorbidities, including cardiovascular and chronic lung disease, as well as diabetes. These groups tend to develop more severe disease and have higher mortality. Therefore, steps that vulnerable patients can take to minimize their risk of infection with COVID-19 should be encouraged. Those measures and recommendations are developed by state and federal government and health departments. Practicing good hygiene and social distancing are the most effective means of risk reduction at this time. You should encourage patients to follow the advice from the state and federal government in this regard. You can refer them to the official link below. Influenza vaccination is recommended for all patients with IBD and should be encouraged when it becomes available this year. In addition, smoking is a risk factor for both IBD and COVID-19, and cessation should be encouraged. Pneumococcal vaccination is also recommended for patients requiring immunosuppression unless contraindicated. Details of pneumococcal vaccination indications can be found in the GESA-IBD clinical update. Please see the link below. Please minimize direct contact between physicians, nurses, and patients wherever possible. Therefore, remote patient management via telehealth and telephone are encouraged. You can utilize the new telehealth and telephone MBS bulk billed item numbers. Please see the link below. If infusions can be performed outside of the hospital or in a location in the hospital that minimizes risk of exposure to patients, then this should be implemented. For appropriate patients in long-term stable remission, infusion interval lengthening may be considered. There are inadequate data available to recommend switching from intravenous biologic therapy to subcutaneous therapies. Non-urgent endoscopy for IBD patients, such as surveillance or routine post-surgical disease assessment, should be delayed. Non-invasive biomarkers and imaging should be utilized for disease activity assessment wherever possible. Endoscopy in symptomatic patients, where the results will affect management, should be considered depending on your hospital's policies. When performed, appropriate PPE should be used as per your local guidelines. Patients do not routinely need to be taken off immunosuppression or biologics. They should be continued on the minimum level of immunosuppressive or biologic therapy to control disease activity and minimize risk of flare. Some patients with long-term stable disease may be able to be considered for a drug holiday. For patients flaring, it is important to treat their underlying disease regardless of their COVID-19 status, and this includes initiation of steroids or anti-TNF therapy in the setting of severe disease. Exclusive enteral nutrition may be an attractive alternative for patients with Crohn's disease. For patients with symptoms concerning for COVID-19 or exposure to someone with known COVID-19, they should be self-isolating and tested per local guidelines. Management of immunosuppressive medications will be on a case-by-case basis. For patients who contract COVID-19, consider holding therapies that may impact the ability of T-cell-mediated viral clearance, such as thiopurines, anti-TNF agents, ustekinumab, vedolizumab, and tofacitinib. Typical symptom duration is 3 to 5 weeks, and a pause in therapy of this duration is unlikely to precipitate a major IBD flare. If you do have any patients with IBD that develop COVID-19, please consider enrolling them in the International Registry. The link is below. Thus far, the majority of IBD patients with COVID-19 that have been reported have not required hospital admission or an ICU admission. I hope you find this guidance useful. If you have any questions or concerns, please leave a comment below, and I will try to address it.